So now, to introduce our speaker for tonight, we are joined by Dr. Jake Bush. Dr. Bush is a recently qualified GP working in a fairly large practice and a BSMS alumnus. After graduating from BSMS, he undertook foundation training at University Hospitals Southampton before working in University Hospitals Sussex as a fellow in elderly care and frailty, and subsequently completing GP training. Jake also developed a prototype for the BSMS virtual work experience course, which I know many of you have engaged with, and which I think, Jake, makes you a bit of a celebrity here. So thank you so much for being with us tonight, and I'll hand over to you.
Well, thank you, Agatha. So you make me sound so much more qualified and better than I actually am, but thank you very much. So hello everyone. Yes, as Agatha said, my name is Jake. I am a local GP. When I say local, I live in Worthing. And I work as a practice as part of a team of about 10 doctors. And we run a practice which has about 16,000 patients. So there's quite a lot of patients. And I was delighted when Agatha asked me to come back and have a chat to you guys. So I just wanted to talk about really what actually being a GP is about and what a typical day in the life of a GP is. I think that's quite important to know. And I know that sort of 50% of people who actually train to be doctors, they eventually become GPs. So you do have to have quite a good understanding of actually what a GP does. And actually what the job entails. So one day, you never know, you might do sort of general practice yourself. So what I'm going to do in this presentation is talk briefly about my career to date, which Agatha has already done a little bit. I'm going to talk about the reasons to do general practice, and there, believe it or not, there are some really good reasons to want to do it. I'm going to talk about what the typical day is working as a GP, and difficult to do that because actually every day, it's a bit cliche, but every day is different. But I'll do my best to come up with something for you. I'm going to talk about some of the cases that I've recently seen as well that have been quite interesting and have quite good sort of learning points as well, which highlight some of the good areas of general practice. I'm going to talk about some of the additional roles and responsibilities that GPs have. Because it's not all just sort of seeing patients, there are additional things you can do as well. One thing I'm going to particularly talk about is duty doctoring as well, because it's not all just having patients booked in with you that you see. You do have to be the boss for the day sometimes, so I'll talk a bit about that. I'll also talk a bit about GP training, and I think it's an excellent training program actually. Hopefully sort of give you an understanding of what it takes to train as a GP in the NHS. And one interesting field which has kind of emerged even in the time that I've been sort of training as a GP is the use of artificial intelligence in general practice. And I'll talk about how we use that at my surgery as well. So just briefly about my career route. So as Agatha mentioned, I was actually a BSMS student. So I went from 2011 to 2017. So actually quite a long time ago now. While there, I did intercalate in neuroscience as well, as that was an interest of mine at the time. I also did the first prototype for the BSMS Virtual Work Experience program, which, as I understand, has been quite successful. I think that the BSMS team have made a few minor adjustments to what I initially made, but I've heard it has been successful, so which is very pleasing to hear. I was a net foundation doctor at the University of Southampton, and that was sort of 7-8 years ago now, actually. And then I was a clinical fellow at Worthing Hospital in elderly medicine and frailty, which is a particular area of interest to me. And then I did GP training for the last 3 years, and I qualified as a GP last year. So currently I'm at Strand Medical, which, as I said, is a local sort of GP practice in Worthing, and I've been working as a GP for them for about 6 months now. They were my training practice, which means that I spent my final year as a registrar, so a final year trainee working at the practice, and they just saw something in me clearly that they decided to keep me on, which is very fortunate. So there's lots of good reasons to want to do GP that I'd like to sort of highlight to you. Okay, so there's as you can see, sort of quite a few reasons here. Just some of the reasons why you would want to do general practice. Work-life balance is a big one, and that's a big reason that people do go into general practice. Variability in what you see, so you can see basically any medical problem from any specialty. It's probably one of the bigger reasons why I decided to do general practice, really. You get some continuity of care as well, so you can see patients over sort of a longer period of time and manage their health problems over a longer period, which is very rewarding. And I'm quite young in my career so far, but some of the GPs I've worked with, they've seen sort of patients as babies who are now in their 20s and 30s, which must be quite an amazing thing to see, really. There's also sort of autonomy as well. So you can be your own boss. You can do medicine how you would like to do it, and you could be a good GP and make completely different decisions, shall we say, to another good GP as well. And we all do things in a slightly different way, but that doesn't mean that what we're doing is wrong necessarily. There's good flexibility of working, so kind of ties in with work-life balance. So you can work sort of part-time, you can work certain hours. Sometimes you can even work weekends as a GP, and you can work in different areas as a GP as well. So one of the common areas where people work as a GP, you may not know, is actually in hospitals and in sort of urgent care, in A&E sometimes as well. And I'll talk about some of the other areas as well that GPs can work in. I realised some of the hexagons that I've actually duplicated some of the answers, which is annoying, but that's okay. It doesn't matter. Leadership as well. So important skill for GPs to have, particularly if you want to be a GP partner. So actually run GP as a business, which is kind of how it's done now. And again, one of the bigger reasons why I wanted to do general practice was you get to work in a small tight-knit team of different people, and you can, and that is really important that you're able to do that. You can really do good for patients by working well as a team. So, okay, so I'm going to take you through my sort of typical day as a GP now. So I'm going to try and make it somewhat interesting. I think there are going to be naturally some less interesting bits to it. So. So hopefully I'll get it somewhat engaging. So I get in at about 7:30, so it's quite early starts, generally speaking. Some of the other GPs, they get in a bit later than me, but I prefer to be a bit earlier so I can get through some of my admin. So there's a few sort of bits of admin that I do tend to get through early in the morning. I don't tend to call patients at this time because patients are rarely actually up at this time. They're often in bed. So I tend to spend that first hour just going through things. So the three things are really sort of test results that I've requested. So for example, yesterday I got about 50 blood test results that I needed to go through, which is quite a lot really, especially as many of them require some kind of action or decision making behind them. So I also get results about X-rays, swabs, any other sort of imaging and things that I've done as well. And also, colleagues aren't always in, and the colleagues that aren't in, any test results that come in that they've requested, we also have to sort of deal with as well. So there's quite a few results that you have to deal with per day, I would say. I also look at letters that are sent to me, so sort of discharge summaries from hospital admissions that patients have had, clinic letters as well from specialists that patients have seen. Sometimes I even get emails or letters from patients, which is becoming more and more common nowadays for some reason. But you do have to kind of respond to them as well and decide what to do with them. And the other thing is tasks. So it's basically you're given tasks by certain people in the practice. I tend to get about 20 to 30 of these a day. That's quite a lot. And often it's along the lines of writing referrals, doing prescriptions, and again, sort of patients calling in and wanting sort of help or follow up, something like that. So. Okay, and so from 7:30, patients can request to be seen urgently on the day, and we use an online form for that, and I think that's generally what is happening nowadays, rather than having the sort of 8 a.m. rush, which is probably what you've heard about in the news. We use an online form. It takes you through an algorithm, basically, and you can describe exactly what your symptoms are, how long you've had them for, any other issues that you feel are important. Patients generally find it works quite well, actually. So sort of looking on the left here, you can see all of the options that you can pick. And on the right side, sort of an example of sort of you can indicate where the problem is that you're experiencing and other details and things. So. Okay, and for my own days, I have 28 appointments. So quite a lot of appointments, really, 28 conversations that you've got to have in the day. And 20 of these are sort of bookable appointments. So they're either on the day appointments that have been triaged, and they're always booked up. And then there's 8 other slots divided into 4 face-to-face and 4 telephone that generally you book yourself, and generally they're booked up as well. So yeah, I do see about 28 patients plus extras a day. So it's quite a large number of patients really to be dealing with. Initially, every appointment is a telephone appointment, and you find actually nowadays that you can deal with probably 2/3 of issues that come into general practice you can just deal with over the phone. So you don't need to see people face to face necessarily anymore. So, if you do need to see them face to face, you can just book them into your schedule. There's no specific times you can do that. You can just book them anywhere you want to sort of organize your day. So the way we do things at our practice, I think, works really quite well, and patients really like it as well. So this is literally what my slots for the day look like. All of them get filled up with patients, and you can see at the end I have 1 or 2 home visits normally as well, which are undertaken sort of just after lunch as well. So. Okay, so between 8:30 and 11:30, I generally see patients and sort of plan my day as well. So what I put in front on the sort of slides here is yesterday's patients that I saw, basically. And you can see sort of from the start that there is quite a significant variety in what we see, sort of highlighting what I said earlier about the variety of problems that you can see. So you can see I've seen a case of depression there. At the top there, and then I saw a child with conjunctivitis. I then saw someone with what we call cervical radiculopathy, so basically nerves coming out of the spine being compressed, and sort of quite a sort of wide variety of issues, and some of them require quite significant action. So, for example, if you look on the second column down the end on the light green. I saw a lady with a nasal fracture following a fall, and she needed an ENT referral, basically. I needed to call the hospital to ask them to see her. When you break your nose, there is a window where about 2 weeks where you let the swelling go down, and then you send the patient to hospital, and then we break the nose again and put it back into position if it's deviated. And I did that actually as part of my GP training in an ENT rotation, so just quite good fun, really. So, but I also had consultations with multiple different people as well. So a lot of these you can assume I spoke to the patient, but all of the children I spoke to the parents. For all of the elderly patients, I actually spoke to relatives. You can see in the bottom right-hand side, there was a double appointment there for an 18-month-old with turns out they had bilateral otitis media, which means bilateral middle ear infections, basically. But the mum was deaf, so I had to sort of come up with novel ways to try and sort of communicate with her. Unfortunately, we couldn't get an interpreter in time. So we have to sort of communicate with lots of different people, but also adapt our communication styles depending on the consultation often. So, okay. And so there's home visits also that I mentioned at the bottom as well. And what I'm going to do is focus on a particular case now, which I thought was really interesting yesterday. for me at least. Yeah, just to show you the kind of thing that you can see in general practice. So the first case is a 4-year-old girl, and she came in with a rash on her hands. So it's not an uncommon thing really to see. Often children who come in with rashes, it's most of the time it is due to some kind of viral illness of some kind. But this was the picture of the rash. It's not actually her. It was the closest thing I could find online, basically. And this is quite an unusual rash. Normally they're a lot more sort of red and pronounced, and not as numerous in the spots. We call that a petechial rash, actually. So that's where the blood vessels are leaking, and it's non-blanching, which means that when we push it, it doesn't go away and then fill up again. It just stays the way it is. If you see a non-blanching rash, that's generally quite a concerning sign. You worry about things like meningococcal septicemia. Wasn't the case in this child, though. They were completely well otherwise. So they had a recent, what we call an upper respiratory tract infection, so basically like a cold or a virus, about sort of 3 weeks prior to me seeing them. When I examined them, I found the rash, but they were otherwise normal in their observations, so things like temperature, heart rate, things like that. They did have a urine test which showed blood and protein in, which is an abnormality. If that's what you find in a child, then it is that is abnormal and that needs investigation. So actually, I made a diagnosis of something called Henoch-Schönlein purpura. Don't worry if you haven't heard of that necessarily, but it is basically where the blood vessels get very inflamed. Our immune system attacks them, and then you get all of these petechiae, basically, these spots. You get joint pains, you get tummy pain, you can get kidney problems as well, which would explain the bad urine. So this normally requires a referral to pediatrics, which is what I did, and they saw the patient at hospital. I haven't actually chased up on the results of that, but I believe that they did become a bit unwell when I referred them in, so I'm very glad I did. I suppose my point is here is that you can see quite unusual, you can see general practice is often where you see the first presentation of common illnesses, but also rarer illnesses as well. So you need to be aware of those as a GP. Okay, so in this case, I think thorough history taking is very important. That there were certain clues here which indicated a diagnosis of HSP. You have to have a knowledge of and consider serious causes for the patient's symptoms. Luckily, in general practice, most of the patients we see are generally quite well. And them being more unwell and needing hospital treatment, that is a rarer thing, generally speaking. But saying that, you do get these presentations. And as I've said before, you will be the first person that encounters rare presentations of illness often. With children, you have to be especially cautious because they can look very well. Their physiology is very sort of competent and they can hold their own until they can't, and then they drop off a cliff. So you have to be quite cautious of that. If in general practice, if you ever feel that you need specialist advice or same day sort of advice, you should always have that safety net to refer if you need to, basically. Okay, so that's just an example of sort of one of the cases I saw yesterday, which I thought was quite interesting. And I would see patients from 8:30 to 11:30 generally. And then what we do as a practice is we'd have basically a coffee and a crossword, which is something that we've had that the practice has had for several years. And it's actually really important to have that. One of the big reasons I wanted to stay at my practice was because they actually were social and they wanted to get people together, because actually being a GP, working in your clinic room all day by yourself, speaking to patients, but not having that sort of non-clinical interactions, that can be quite isolating. So I wanted to go somewhere that had a strong team, but also somewhere where you could actually have a social element to it as well. So so we talked about sort of non-work things, but we would also talk about difficult cases that we've seen. Often we can get advice from other GPs who perhaps have more of an interest in a certain area. We also spoke about the events and sort of proposals and projects that were going on within the practice and locally as well. Sometimes we talk about practice performance and how well we were doing on things like quaff and how many appointments we're offering and how many we're filling, that sort of thing. We talk about complaints. They do come in. So I've only had one complaint, I think, in the past 18 months, which actually isn't too bad. But you do get complaints, and even the best doctors will get complaints. So, and then we also talk about socials as well. So we had the Christmas party a few months ago. We're planning to have a quiz night soon, which should be good. Lunch 12:30ish, and then after that, we'll possibly see patients, but often actually do home visits. And home visits are quite a big part of general practice. So there's sort of three groups of patients that we would normally see on home visits. So there's patients who sort of live in their own home, but they're housebound. So for whatever reason, they can't leave the house and they can't get down to the practice for us to assess them. We've got patients in residential and nursing homes as well. So we don't actually have that many in my practice, which is quite odd, as Worthing has quite an elderly population, but we don't have many homes. And then there's patients having sort of end-of-life care as well, which is another big part of what we do. A lot of these patients that we see, generally speaking, at home visits, they have a significant frailty. They have significant numbers of comorbidities. They also typically take lots of medications as well. And they sometimes have they often have care as well. So all of this you have to take into account when going on home visits. So we're actually quite lucky because while we do a lot of home visits, we do have a couple of paramedics who actually do the majority of our home visits. So we normally have one paramedic a day, and they take on about 10 visits, which is really good. And they take quite a significant workload off our hands. It used to be the case that doctors would have to do 4 or 5 visits, often in their lunch break, but that's no longer the case anymore, thankfully. So, okay, so going back to my sort of day, I'm circling the sort of home visits at the bottom here because I'm going to go through a case that again I saw yesterday at the patient's home, which I thought again was quite interesting and raises some quite interesting points about home visits. So, okay, so this is a sort of 79-year-old male that I saw, and he called us because he was getting breathless. It was acute on chronic breathlessness, which means that he's been breathless for a long time. That's what chronic means. And then the breathlessness has got worse in the last few weeks. So we say acute on chronic, therefore. He has a background of prostate cancer and had a previous prostatectomy in 2019. Which means that they just basically remove the prostate and some surrounding tissue as well to try and remove the cancer completely. He also had a background of COPD and anxiety as well. He's not left the house since before the first COVID lockdown in 2020. So it is quite amazing, isn't it? And you can see how even now the impact that COVID and the lockdowns have actually had on some patients. It's lasting even to now. So he's an ex-heavy smoker, and when I got to the house, it was very cluttered. It was quite unclean, and there was clear evidence of what we call self-neglect, basically. So evidence that he hadn't looked after his physical health very well. And he confessed that he doesn't like seeking sort of medical care or bothering us. Chiefly that was due to anxiety, I think, more than anything else. But it's interesting because there is probably an iceberg of patients almost that we just don't know about in the community. And it's only because his breathlessness has become so bad that he's reached out to us now to try and seek sort of medical help. So what I did was I examined him, and he was a bit breathless. He was very pale, very pale. So, and he had some swollen legs with what we call a pitting edema. And what that means is basically you have a swelling of the leg, and if you put your thumb on there, leave it there for 5 seconds and take it away, you're left with an imprint, as you can see sort of on the right side there. That's called pitting edema. So what I did then was I did some blood tests, as I wanted to see if there was a reason for the pallor and the pitting edema. And his hemoglobin was very low. So just to give you sort of a reference, a frame of reference, so an adult male's hemoglobin should be between sort of 130 and 160, 170. Yeah, his was 69, so it's about half as high as you would like it, really. So his MCV of 50 was very low, and what the MCV is basically the size of the red blood cells, and that's almost certainly because of his iron was low. So we call this an iron deficiency anemia. Anemia just means low hemoglobin. And he also had a raised what we call brain natriuretic peptide, which is basically a chemical that's released by the heart when the heart is in stress. And it is a very sensitive marker for something called heart failure, which causes pitting edema, which is why I did the tests. He had a chest x-ray, which thankfully didn't have any fluid. Sometimes when you have heart failure, you can get fluid on the lungs, but it didn't suggest that in this case. But it did have some features of basically emphysema, COPD. So my diagnosis at that point was sort of iron deficiency anemia, query cause. So I'm not quite sure what was causing that at that point, but what I did know was that needed further investigation. Heart failure, and also significant sort of self-neglect and basically a dire social situation, really. Yeah. So it's actually the case that a lot of causes of anemia are related to gastroenterology, so problems in the digestive tract. So I've arranged an urgent referral to gastroenterology for him. I've arranged something called a FIT test, which is a test we do very commonly in general practice. It basically looks for microscopic blood in the poo that you can't see, and it's a very sensitive test again, so it's good at picking it up. And if that's positive, then you need to generally refer patients for a colonoscopy, so a camera test to look at the bowels. I've referred them to cardiology, as you should do in anyone with suspected heart failure. I've also prescribed him some iron replacement to try and bring up his hemoglobin again. I was toying about whether or not to send him in for a blood transfusion, but I've decided not in this case, to see if we can bring it up in the community. I don't think he'd go in anyway, even if I asked him to. So I did offer him some water medicine. He also declined this. And I also recommended they actually sort of talk to social care to see if we can get some help for this guy. So sort of the takeaways messages from this case really, I think, are that sort of home visits are a really good way for actually seeing how patients live in their own home. Because when they come in to see us in the surgery, you know, we get a 10-minute snippet of how they are in another place, basically, and how they're managing things. But that's nothing compared to actually seeing how they live in their home, sort of how well kept things are. You know, do they have access to bedrooms? Do they have access to toilets, cooking facilities, that kind of thing? It's a really good way to sort of put their health problems into context, really. So, as I mentioned before, there are some patients which we just don't really hear about because they don't contact us or they don't respond to invitations for blood tests or chronic disease monitoring appointments. And it's not just us that don't know anything about patients. Sometimes they're just never seen out and about. They don't really speak to friends, family, relatives. Yeah, there's as I said, there's probably quite an iceberg of patients that we just don't really know about, and it's quite difficult to see them sometimes. Yeah, as I've said, the impact of sort of COVID and lockdowns, it still kind of persists today, and also the importance of sort of thorough clinical examination and looking for clues as to sort of why the patients are presenting in the way they are. Yeah, it's important that you're sort of thorough in that, particularly on your home visits. you might not get the chance to examine patients for a while again if you're going on a home visit. So you have to be really thorough. And then there's the thought about general practice is different to hospital medicine. In hospitals, you can request a test and you can often get a result within hours. However, it's not quite like that in general practice. You often, if you request blood tests, it's often booked a week, 2 weeks down the line. Things like X-rays, other tests, they take a long time to arrive. So you have to think, oh, well, can I really wait for these tests? Do these patients need to be referred to hospital to have these tests done? So yeah. Okay. So again, so in the afternoon, I would sort of see patients again. So I do the sort of right-hand column of my list, generally speaking. And I'd like to speak about a case that I've seen recently, well, a few days ago. That was on my afternoon list. So this lady is 72. She presented because she has been monitoring her blood pressure, and she was found to be high. She's a lady who I've known for 7 or 8 months now. She's had a stroke with left-sided weakness and leg swelling causing reduced mobility and what we call dependent edema. So basically, she's not moving around that much. Her legs are below her body for a lot of the time, and so fluid is just accumulating in the legs. So yeah. She was previously independent, and she experienced a dramatic reduction in her independence, as you might well predict. She's now using a stick. She's quite unsteady on her feet. She's unable to drive as well, and that's something that patients really care about. One of the most difficult things that we have to do as doctors is tell people that they can't drive, actually, and that's one of the things I find most difficult. So she actually previously complained to the practice, and I mentioned complaints earlier. So they do happen. She didn't feel she received enough support and care after her stroke from her GP, and she also felt that her leg swelling wasn't being properly addressed. So that's when I became involved in her care and tried to address her complaint. Actually, it turns out she had quite high expectations of what to expect in terms of the care post-hospital, basically. There's no way we could provide the same level of daily care that hospitals provide, is what I'm trying to say. But anyway, we became sort of well acquainted, actually, and now we have quite a good sort of relationship with each other. I've particularly been involved in trying to manage her blood pressure. But that was really difficult because she was very sensitive to a lot of the medication changes that we did. So I would increase the dose of her blood pressure medication, for example, and then she'd start getting very dizzy, getting what we call postural hypotension, which means that when she stands up, her blood pressure just plummeted and she got really dizzy. So that was quite tricky to manage, actually. So I did her blood pressure in clinic. It was 155/80. So for reference, a normal blood pressure should be less than 140/90, generally speaking. Because she's had a stroke, we're probably aiming for a bit lower than that 140/90, actually. So hers is clearly higher than that boundary. So what I did was I adjusted her drug regimen. I split the doses of one of her medications into morning and evening so that the effect of the drug would be balanced. And I also reduced the dose slightly as well, and advised her to continue blood pressure monitoring and some follow-up as well. Okay, so some things you can take away from that are that actually continuity of care is still actually a really important aspect of general practice. A lot of people feel that continuity is kind of being lost now as we tend to deal with a lot more urgent cases, and GPs aren't always in every day of the week to see patients who request a review. But it is really important, and we do try to ensure, at least at our practice, that patients are seeing the same GP for the same issue at least. And I've seen this lady probably 3-4 times in the last 8 months. And it's just easy because we understand each other. I know what her expectations are. I'm able to sort of properly make medication adjustments that I think are safe. So Also about complaints, the best doctors will get complaints, and the vast majority of complaints don't lead to any kind of disciplinary action. It can often be settled kind of quickly, really. They do often come from places you don't expect. So I thought this lady actually had rather good care after her discharge with stroke. But nonetheless, we did get a complaint, actually. And you can have some terrible consultations, which you think patients do complain and they don't. So what I'm saying is that they will happen, but don't be too down if they do. As I said, patients can have very high expectations, and one of the jobs of us is to kind of set realistic expectations of not only what the service is that we can provide, but also what the outcomes of someone's illness will be. So in every consultation, I try to set, for example, a timeline which I expect things to get better, and that's really helpful, as that can sort of help prevent patients from presenting early again with the same issue. That actually will just get better with time. Therapeutics is actually a really important part of GP. And when I say therapeutics, I mean sort of drug management. And often it is individualized. So particularly with this lady, you can't just tinker majorly with her medications. Potential for sort of bad side effects and her not tolerating the medicines will be quite high otherwise. But you often have to, majority of patients actually, you do have to think about the therapeutics in quite a bit of detail. And particularly with those frail patients that I often see who are on 10, 15 medications, it can become really tricky. Okay, so there are variations to this kind of structure of days. So sometimes you can replace the second half of the day with sort of baby checks. So these are booked in. I probably do these every sort of couple of months, and 2 or 3 baby checks are sort of booked in. For every baby who's born in the UK needs to have a baby check with a GP at 6 to 8 weeks. They do have a newborn check as well. So when they're born, they're checked for major abnormalities and certain specific abnormalities as well. And then we have to kind of repeat that process at 6 to 8 weeks just to make sure that nothing is missed. And those are sort of quite sort of nice consultations. You check on the welfare of the baby, but you check on the welfare of the parents as well. You also do things like taxi and DVLA medicals. So anyone who drives for a living generally has to have a medical that's signed off by the GP, just to make sure that they're safe to be driving that much and to be doing what they are doing. Generally, they're absolutely fine. Sometimes you get admin time. So we're lucky to get specific admin time that is rostered every 2 to 3 weeks into our rota. So I'll often have an afternoon where I can just sort of get through my admin as quick as I can. I never managed to get through all of it, though, because there is a lot. There's resus training as well. So even in general practice, you have to be able to provide sort of basic life support. Thankfully, I haven't been involved in anything like this yet. I did have someone come in on Friday with acute asthma. They didn't require sort of VLS or CPR, thankfully, but you do have to be aware that patients can come in with urgent problems unprompted, and you have to be able to do CPR as well. And then we have closure afternoons where we actually give vaccinations. So in the winter, we ran the COVID and flu vaccination program for our practice. So it's something a bit different to do in the afternoon, which is quite good. So. Okay, so one thing I did mention was about sort of duty doctoring. So if you're the duty doctor, then your normal day is you don't do a normal day. What you do is you essentially become the boss, and you sort of get in at 8 in the morning, and you're there till practice close at 6:30. And what your main role is every single patient that contacts the surgery using our system, you have to go through what they said and you have to decide, can the patient be seen does it have to be urgently today? Can it be routine? Can they be seen in a week or two? Or is it an emergency? Do they need to be seen in A&E urgently? So, our system does sort of make recommendations as to whether or not they think it is urgent or emergency or routine. But it's ultimately your decision whether or not where you put the patient, basically. Obviously, the online system that we use is quite risk averse, so it will often make urgent recommendations for things that really don't need to be seen urgently. But there are a few things in there as well that sneak in as routine and actually are emergencies. So you do have to be quite vigilant for that, actually. So there are sort of other roles of the duty doctor as well. So you're the first point of contact for sort of urgent queries, and so any reception staff who need to speak to you about patients who have called in. You accept calls from other professionals. So the other day I was duty doctor, and I had to take several calls from paramedics who were with patients who were registered at our practice. Then they didn't think that the patient needed to go into hospital, but thought they would benefit from an urgent same-day assessment. So I have to discuss with them what to do. I do get calls from hospices as well. So we do have a local hospice near where we are, and sometimes we do get called and asked to prescribe certain medications or to review patients, make sure that certain documentation is in place. Often it is to prescribe medications, what we call just-in-case medications. So if patients deteriorate and they need symptomatic control by use of medications, then I prescribe those and make sure they're delivered urgently to the patient's addresses. So we review 111 cases as well. So anyone that calls overnight on the day before you're working and doesn't need to go into hospital, but again needs an urgent appointment at the GP. And I also sign prescriptions. I probably sign about 300 to 400 a day when you're a duty doctor. So there's quite a lot of prescriptions that you have to sort of go through and review. That is quite tricky to do safely, but we do manage it just about. And then you're also the boss of home visits as well. So so you can assign home visits to people who are working that day, and you also have a chat with our paramedic who goes out to see the patients and then comes back. You chat to them about the home visits and decide on the management plans, basically. Yeah. So that is a bit more sort of requires a bit more leadership, a bit more coordination and delegation, and a lot of decisiveness as well. You have to have when you do that role. You're probably duty doctor once every week or two, I would say. It's quite a big part of your job. Okay, and I thought I'd sort of start to wrap things up by talking about sort of GP training. So I think the training program is excellent. So it's 3 years full time. It's an excellent sort of opportunity for sort of part-time training as well. So I think about 2/3 of trainees are actually part-time, or less than full-time, I should say. So some people do sort of 60%, some people do 80%, actually. So it's really good for that. You also get guaranteed teaching time within your training, which is really quite rare actually in medical training. You don't often get guaranteed teaching time. So for example, where I was, you get every Thursday. Thursday mornings, you typically have some talk or some lecture, and then Thursday afternoon is dedicated to your own time, basically spent on portfolio, things like that. So you get to go to a lot of different placements. So I did lots of placements. I worked in pediatrics, I did obs and gynae, mental health, I did ENT, I did respiratory medicine. In the final year, though, you're exclusively in general practice, which is really when you start to sort of make the transition from being a trainee to being an actual GP. So you do have assessments, but they're generally all right. The portfolio is quite long, so you have to do over 100 reflections over 3 years, which sounds like a lot, but most people do get through it. You have a knowledge test that you have to do called the AKT, which is quite a hard exam actually, and the SCA as well, which is basically an OSCE. It's over Zoom, and it's a clinical exam where you basically go through the surgery from hell. But yeah, most people do get through them. So it's actually quite competitive now, GP training. So even when I applied, the sort of competition ratio was about 1-to-1. So everyone applying was kind of nearly guaranteed to get an offer somewhere. But nowadays it's actually probably about 3-4 to 1. So it is more competitive, and for some reason more people are going into general practice now. So yeah, so just sort of an overview of sort of where you could be. So you've got medical school for 5 to 6 years, foundation training for 2 years, and GP training for 3 years. You could potentially, even from starting medical school, eventually become a GP in 10 years, which isn't really that long actually. So the training program is quite short, and it's a good program as well. And by the time you're a GP, you'll probably be working for 40 plus years or something along like that. So I thought I'd highlight as well that in general practice, you don't just have to sort of see patients in your practice anymore and just do the same day all the time. Probably the majority of GPs are choosing to focus on one area or another, basically. So we have a GP in our surgery who can do joint injections, for example. We have a couple of GPs who are involved in training of GP registrars and people on the GP training program. And that's something I'd like to go in personally. Some GPs specialize in ENT, dermatology, women's health, and we have someone in the practice who does that. GPs are involved sometimes in minor procedures, so things like removals of lesions, like skin cancers, for example, vasectomies, that sort of thing. One thing also that I'm interested in is frailty. So I do like to sort of take an interest in some of the lead on some of the more complex frail patients in the surgery, and MSK as well. So AI. So we do use AI in our practice at the moment, and this is something which actually emerged even in time I was training as a GP. So really recently, currently we use it only for consultations and for letter writing, basically. So I think it's great. So what we do is it essentially listens to the consultation. So let's say I'm having a consultation on the phone, it will listen into the consultation using a microphone. It will write the consultation up in about 5 seconds, and it writes it nice and eloquently with no spelling mistakes, and it will include all the detail often that you need. So it's great for documenting boring essentials. So for everyone with a headache, for example, you want to ask, is it sudden onset? Did it go from nothing to severe headache? And do you wake up with vomiting? That sort of thing. And it will document all of those things that are quite laborious to document generally, and that are necessary for sort of indemnifying yourself. And you can use the same transcription, so the same recording, shall we say, of the consultation to then write other letters. So referrals often is the thing. Letters to patients, it can write a summary letter that you can give to patients at the end of the consultation, pretty much in 3-4 seconds, which is incredibly useful. There are some problems with it though. It's not perfect. So for example, there's been a few cases where it mishears the name of the patient and then will write either a different name or incorrect spelling, and that can be problematic. And patients sometimes find it on their records that they've been called another name, which is quite funny, but it's not ideal. Sometimes it can miss important information or information that it does not deem to be important. So I like to describe a lot of the social history, for example, particularly with frail patients, but it often just doesn't write that down. But that is quite important information. It also does something called hallucination, which is where it just makes up something that just didn't come up in the consultation. So I had it the other day where it made up that a patient was a beekeeper full time, but that just wasn't the case at all. I don't know where it got that from. So you do have to very carefully check what is written and make sure that there are no mistakes there. One thing I've noticed is that all consultations sound and look really similar because it puts them in the same sort of framework every time, and it uses the same way of articulating. So often when I go back to my previous consultations, and I don't really recognize them because I haven't written them. So saying that probably saves me about 2 to 4 hours each day, I would estimate, at least. So it is incredibly time saving. So I'm all for it. Okay, so wrapping up soon. So I thought I'd highlight some of the most important skills that I think a GP needs. These are sort of my opinion. So some GPs might disagree, or they might have other skills which aren't included here that they think are equally or more important than these. So decisiveness is really important because you get so many decisions that you need to make in even just a typical day. So you need to be able to make quick decisions. And if you don't know the answer to certain questions, you need to quickly find a way of working out the answer or forwarding the process. So I'd say decisiveness is really important. Efficiency as well. Your time is so precious as a GP. So you need to have not shortcuts, but ways of doing things quickly and in as little time as possible, but also making sure that you're doing a detailed and comprehensive enough job. Sort of getting to grips with that, I think. So delegation, so something which is something which you develop, I think, as you get to know the teams better. You can know, once you've worked there for a while in a GP surgery, you get to work out, who does what and who is appropriate to delegate certain tasks to, because you get so many jobs in the day. There's no way you can do them yourself. You need to distribute amongst the workforce and ask people to do jobs for you, and that's the GP being efficient, but also being a leader as well. Communication is, I think, maybe the most important on this list. If you're having 30 plus consultations a day, you need to be a good communicator. You need to be concise. You need to be, but still comprehensive, and you need to you need to be able to get the important information that you need quickly from the patient, and also communicate your management plans to patients concisely and efficiently. You also have to adapt your communication to patients as well, because some patients, for example, won't have a good literacy. I mentioned the other patient earlier who was deaf, so I had to try and adapt my communication with her quite significantly. So yeah, you have to adapt your communication to patients. And I also include communication with other people as well, so staff at the practice. So you need to be, sometimes you need to be firm, for example. So you need to be sort of, sometimes you're a teacher as well, and you can be educational. And then there's team working as well. So I'm delighted to be part of a small practice where we have lots of different members of the team, and they're all sort of excellent to work with as well. It's not always the case in general practice, but it's not all great. So there are some things here which I thought I'd highlight, that there are sort of realities of general practice which aren't particularly pleasant. So the workload is high, and particularly that step up from being a GP trainee to a GP is quite significant, actually. And I'm still adjusting to that myself, I would say. It can be quite isolating, and I've mentioned that one of the criteria for me joining my current practice is that it was more sociable, shall we say, than other practices, and there was more of a time to see the other GPs and have a chat about things like cases and things like that. So it wasn't always the case at other practices that I was based at. And it's heavily computer-based, the job. I think you should know that before sort of going into general practice. You do spend majority of your time, at a computer with patients, but it is a really big part of the job, I would say. Job availability at the moment, it's actually quite difficult to get a job as a GP at the moment. And a lot of people are graduating but are having difficulties finding jobs in their local area, which was unheard of even 5 years ago, and is a bit sort of paradoxical, isn't it? Because it's not like their doctors aren't needed. It's just that there's no sort of hiring power locally. So patient expectations I've kind of talked about, and also financial pressures more applying to sort of if you're going to, as a GP, buy into the business and become a GP partner, you have to provide certain services with limited finances, and it can be quite difficult to run that business effectively. So for further info, I'd probably go to the Royal College of General Practitioners to look at, because they have good sections on sort of the role of a GP. It's very comprehensive, actually. If you wanted to find out more about GP training as well, that's quite good. NHS England have some information on it as well. B&J Careers, there are a few articles that describe, for example, GP training in particular good breadth. And then you can look at the GMC as well, particularly their good medical practice guidelines. So. Okay, so I think that's all I have to say. I hope it's been somewhat interesting, and I hope I've sort of shown general practice in a good light, but also quite a realistic sort of light as well. I have no regrets about going into general practice at all. I really enjoy my job, generally speaking, and I'm pleased about how things have turned out. And so thanks for listening.
Thank you, Jake, for such an interesting presentation. I really enjoyed kind of getting that overview of your day as a whole, and then delving into those patient cases and the different roles of being a GP. And you really demonstrated like that sort of variety. I was kind of really struck by like that second case where you went to see the patient who, you know, is not often being seen by medical professionals, and then the third case where it was that patient who you'd really got to know and built that relationship with over a series of months. I found that, you know, a really striking contrast. So yes, so thank you. I can see the audience were really engaged. There are some great questions in the Q&A. Do you have a couple of minutes for some of the questions?
Yeah, sorry, I think I overrun a bit, didn't I? I didn't mean to, but yeah, definitely have you questions. So.
That's great, Jake. It's not a problem for me to overrun, as long as it's not for you. We'll get a couple of questions in. So Neelam has asked, when patients come in with problems, do you always already know the answer, or do you have to do some research?
That's a good question, actually. So often I already know the answer. Is probably true. So the advantage of patients using, for example, online systems is that they can submit information pre-appointment. So they'll often list their symptoms, and then they will, and you'll look at the combination of those symptoms, and you go, oh, okay, I think I know what this is, and contextualize it obviously to the patient's sort of record, because you've got that in front of you as well. You remember, so you've got past consultations, existing diagnoses. So you can often work out quite quickly, even before you even see the patient, what's going on. So not always the case, though. And actually, the most fun cases are probably the ones that you don't. And there are a few of them every day. So, but yeah, I suppose another advantage, as you mentioned, was that if you don't know the answer, you can sort of quickly research for some answers before you start consulting with them.
Yeah, that's really interesting, because I to think about that as an advantage of that kind of online triage form, because I know some people are quite critical of the online forms, and obviously they don't work for everyone, but I hadn't really considered that as actually giving you as the doctor a bit of a chance to maybe have a think and stuff before you actually speak to the patient. That's really interesting. We have a question from Isabel. They've said, you mentioned spending a year doing neuroscience whilst at medical school. I think that was your intercalation. And Isabel says, did you find any benefit to this, and would you kind of recommend doing the intercalated year generally?
So it depends why you want to do it. So I think um, part of it was that I was interested in at the time interested in neuroscience. And conveniently, the Sussex University offered that program for medical students. So I wanted to explore that in a bit more detail. Um, uh, uh, Actually, now, as you can probably tell, I'm not as interested in neuroscience as I was. I'm more interested in dementia and frailty, so an aspect of neuroscience, I suppose. Um, uh, Myself and quite a few others actually took a break from medical school as well, and we used it as a bit of a kind of a hiatus year, if you like, to do something a bit different. Actually, so yeah, I was interested in this, but I also wanted to do something a bit different for a year. I think that was my answer. So.
Yeah, that makes a lot of sense. Cool. Oh, sorry, lost the questions. There's a very interesting question from Victoria, which is, how do you balance respecting patient autonomy with beneficence and non-maleficence when someone refuses treatment, for example, in the case 2?
So patients have autonomy, so they have capacity, and this gentleman did have capacity, which means that he has the right to make unwise decisions, basically. Mm-hmm. Okay, or I say unwise decisions that you deem medically unwise, shall we say? Okay, right. What I find is that patients, despite you thinking that they've made a medically unwise decision, often they make decisions that are actually quite understandable. Actually, so even if you don't agree with them necessarily, so for example, the case 2 with the gentleman who was housebound, who hasn't had any blood tests in 5 years or any medical follow-up in 5 years, I was trying to get him to take iron tablets, for example, and he was very resistant to do that. I did manage to convince him in the end, which is good. You have to make sure that patients have all the information that they need to be able to make the decision. Okay, I'm fine with beneficence and sort of not doing any harm to patients. I don't think that was necessarily doing harm to him, even if he refused it. Actually, so I think there is an ongoing challenge with him. He doesn't want to attend hospitals, for example, for his tests, and he's a reluctant patient, I would say. So he probably won't want me coming on many home visits, unfortunately. But that's not me necessarily doing any harm, as long as he understands the consequences of his actions.
Yeah.
Did that answer the question, possibly?
I think that was a great answer, and that was a real answer, Jake. Thank you. Great. Shall we do one sort of final question? Harris has asked, what is a benefit of being a GP rather than doing maybe a different speciality? And maybe you could kind of say, like, what's your favorite part about being a GP?
So my favorite part of the GP is that essentially it's the variety that you see. So if you do sort of a specialty, you see same problems over and over again. You're an expert in those dealing with those problems to the minutiae. So you know very specific things about a specific thing. Whereas in GP, you're an expert on everything to some degree. Okay. And I showed you my surgery earlier that I did the other day. I saw one patient with blood in the urine, and then I saw a patient with sort of nerve compression in the neck. I saw a girl who unfortunately is probably quite unwell in hospital at the moment with that Penile purpura. And I also sort of so you saw the cases as well that I described with that gentleman at home. You don't get to do home visits often in most other specialties, for example. So, but it's just the variety and the fact that you can go from the first 10 minutes seeing one of those patients to seeing a different one to seeing a different one, and it's there's not many other jobs that you get that kind of that variety, and not many other specialties that you get that variety. I would say also, I've been privileged to work in an excellent team. And I'm not saying that hospitals and other specialties don't have excellent teams, but working in a tight-knit team in the community who really cares about their patients is a real privilege, and I didn't really appreciate that, I don't think, until I started GP training, actually. So yeah, variability and teamwork as well, probably, I'd say.
Yeah, those are really good ones. I loved hearing about the coffee and crossword that your team do. I think that's really nice.
Yeah,
Well, I think we're kind of at the end of our time now, so I'd just like to thank you again, Jake, for coming and speaking to everyone this evening. I really enjoyed it, and I can see, in the chat that thank yous and messages saying how much people enjoyed it are coming through, and I'll make sure I get those to you afterwards as well. So I'd just like to say thank you to the audience for your great questions and for being here with us. And we hope to see you next month.